This is Duke University.
The the theme of this panel is looking at the provider side. Actually, I think this is the first time we've been at Fuqua with a panel of 4 physicians, but as you'll see, people are wearing very different hats, even with their MD degree. But the questions really kind of run the gamut from the science to employer side and how are people thinking about obesity, to the provider side and how is this business opportunity kind of paralleling some of the themes that we just heard. So Will Yancey is a general internist here at Duke, does a lot of work in diet in some of our diet clinics. Don Bradley is vice president or executive vice president?
Senior vice president.
Senior vice president for Blue Cross Blue Shield of North Carolina and is their chief medical officer. And Kelvin Baggett is the chief medical officer at Tenon Healthcare and an HSM alum. So what we've done is asked everyone to talk for a couple minutes about very specific questions that we all keyed up on the conference call. And I think we'll start with Will and just asking the question about the science. One of the, I guess, 2 reflections, Barry went off on his reflections, I'll go off on 2 of mine. One is there's actually no physician specialty of obesity. And so there's no National Institutes of Obesity, there's no medical residency training in obesity, so there is actually no one that owns this. We have endocrinologists, we have general internists, we have surgeons that do obesity work, but there's no one in charge of the science of obesity. And I think we've heard that theme loud and clear that that's one of the issues. You can't tackle a problem if there's not a group of people that are really in charge of doing that, and a process for doing that. A second is the science. We've talked about the magnitude of a public health problem. You would think the magnitude of investment in the public health problem would be commensurate with the size of the problem. And already you've heard a lot that there is not very good science. We don't know why we've gotten obese. We've got plenty of hypotheses, all of which are untested, or the science is really poor. And so at the root of this, even if you wanted to do the right thing, and even if you came to every clinic at Duke to do the right thing, you'd find we'd have very different recommendations at each of our own internal diet clinics because different people believe different things. So Will, how do we clean all that up?
So I've been charged to summarize what we know about the causes and the treatment of obesity in about 5 minutes, so everybody hang on. As Kevin said, we still have a lot to learn, but we do know a decent amount of information. It's unfortunate that we don't have an answer for the problem, but my job became more difficult in the last couple of days as more and more reports came out about obesity. So my interest is in diet, and yesterday, I don't know if you all saw it, but as I was waiting to be called for jury duty, CNN came on with a article about the nutrition professor who lost weight by eating junk food. So he did not help our cause whatsoever. Twinkies and Ho-Hos are probably not the best way to lose weight, but he managed to do it by reducing his calorie intake, and we'll talk about that a little bit. But our big issue here is the prevalence of obesity. It's increased really dramatically in the last 20 to 30 years. So 13% in 1960, 13% of adults were obese in 1960, and now we're up over 30%. So it's what's been called an epidemic. So it's something that we need to work on, and we're not really sure, like Kevin said, we're not really sure what's happening. We have some ideas. It's pretty widely believed, but difficult to demonstrate, that physical activity has declined over this time period. So frequently reported in your articles about the prevalence of obesity, but if you look at leisure time physical activity over those 30 years where the prevalence has increased, leisure time physical activity has not changed dramatically. Now, work time physical activity might be the issue, and it's been pretty hard to assess that. So that's one thing. It's part of what we call the energy gap. So you gain weight by either exercising less or eating more or a combination of the two. The physical activity part of the equation probably is a contributor, but it's not been clearly demonstrated. Changes in dietary intake have been clearly demonstrated, and they are pretty widely believed to be a big etiology behind our obesity epidemic. I think we'll probably spend a little more time later on in the panel talking about what's caused these changes, because that's where the controversy exists, but we know what changes have occurred. We've increased our calorie intake pretty dramatically over the last 30 years. So in the 1970s, women were eating about 1,500 calories a day, men were eating about 2,400 calories a day, and that's increased in women to 1,900 and in men to 2,900 calories. So an increase of about 400 calories per day, or about 25% increase in energy intake. So that's going to cause weight gain. We know that's going to cause weight gain, and that's a big contributor. So what's been the composition of that calorie intake? Well, we have pretty good data from national data sets. The NHANES data set has been pretty widely explored for this issue, and it shows that we've had a change in the types of foods that we're eating over the last 30 years. And the biggest change has been in the proportion of carbohydrates that we eat. So our proportion of carbohydrates as a proportion of energy has increased from, in men, 42% to 49% of calories, and in women, 45% to 52%. So this has been overlaid with the message that we should reduce our fat intake and try to eat more starches, particularly complex starches or whole grains and foods like that. So it's interesting to see that these changes have coincided exactly with the increase in prevalence of obesity. Doesn't mean it's a causative mechanism, but it is interesting to see that they've overlaid pretty prominently, pretty specifically. So sugars are probably widely recognized as the main culprit in this situation, and there are a lot of studies looking at particularly sugar-sweetened beverages. We've increased our portion sizes in those pretty dramatically in this time period, 8 ounces to about 13 ounces or so in the last 30 years. Particularly sodas and fruit juices have increased dramatically. Probably doubled our portion sizes in that time period. The biggest constituents for these, the biggest population segments that consume these beverages are our kids. So one of the articles showed that adolescents drink about 500 calories per day from sodas and fruit juices. So this is a big issue, a big driver of the obesity epidemic, and unfortunately is really hitting our kids pretty hard. There are a lot of other possible causes that we've been examining. Genetics is widely considered. It's hard to imagine that certain genetic changes have caused the obesity epidemic in just 30 years. We know from evolution that it takes years and years and years for these kinds of genetic changes to drive such a thing, but probably the genetic predisposition has been there combined with the environment. So a number of breakthroughs have been made with certain genetic mutations that are related to obesity. We're not exactly clear on how these mutations cause us to gain weight. So they somehow affect our energy intake, they somehow affect our metabolism. There might be a number of other metabolic issues that are brought forth by these genetic mutations. Suffice it to say that it's probably years down the road before we have therapeutic targets that we can use from these types of breakthroughs. But the work is ongoing, and it's still worthwhile to pursue it. Another interesting cause that just came up in the last few years is the finding that our bowel flora might contribute to our weight gain. So this is kind of an interesting breakthrough. It's not something probably you all talk about frequently, but in our medical conferences it is something that we talk about freely, so I'll try to keep the specifics out so we don't gross anybody out. But what they found is with mice who were basically germ-free, if they introduced certain bacteria to their bowels, then they would gain weight. And so they've pursued this finding a little bit further by other experiments animals, and then also looking at humans, and have found that the bowel flora, the types of bacteria in our bowels, are different amongst people who are overweight compared with people who are lean. And they even found that those changes might be evident in children before they become obese. So this is something that's being explored further and actually might have more immediate therapeutic targets because of, and probably you all are aware, that certain products are being marketed like probiotics, which are actual cultures of bacteria that you consume, and they might change the way your bowel flora reacts. And there are things called prebiotics, which are foods that might actually feed the flora and change the composition. And then even antibiotics might be able to alter the bacteria that are in our gut and maybe impact obesity. So that's a pretty interesting development, a possible underlying cause of obesity. And then I think another very interesting possible cause, or another interesting kind of, direction that we've looked at how our behaviors might have changed is our social networks. So interesting research from the Framingham study found that people who were closely linked to somebody socially who became obese, those people had over 50% increased risk for developing obesity. And this link was particularly with our social non-family members. So this I think points to the fact that genetics really has some contribution, but our social networks might have just as much of a contribution to the causes of obesity. So I think those are some of the more commonly cited possible causes to our increase in obesity prevalence. And now I'll try to go into some of the treatments. So similar to what I said about physical activity not being really clearly shown as a driver of the obesity epidemic, it's also not a great way to treat obesity, so especially in adults. So it might be different in children, and I'll actually save most of my remarks for adults because that's where I do most of my research. But losing weight by increasing your physical activity is not the most effective strategy. You can lose 1 to 2 pounds that way, and it's mainly because of an increase in appetite that occurs as you exercise, as you increase your exercise. So diet, I think, is one of my areas of interest, and I'm going to save that to the end. I'll discuss that a little bit in more detail in a few minutes. Medications, boy, this is a difficult time for the pharmaceutical industry. So the last month has shown a number of changes in what we have available for treating obesity, and also some of the developing drugs. So sibutramine, or Meridia, is one of only 2 agents on the market for long-term treatment of obesity, and it was recently voluntarily removed from the market by its manufacturer based on research showing that there are increased risks for cardiovascular disease and stroke in patients taking this medicine compared to placebo. So this is from the SCOUT study, and it's removed one possible medical treatment that we have for obesity. That leaves Xenical, or Ally, is the over-the-counter form. The generic name of it is Orlistat, is the only medication we have available for long-term use. Then there are a few medications in development that have recently been denied FDA approval. Cunexa is one of them. Lorcaserin is another one. Both of these medications had safety concerns. The interesting thing there is because of the increased scrutiny that the FDA is placing on anti-obesity treatments, Cunexa, which is a combination of 2 medications that are already approved for use, has not been approved. So, and again, that's because there's increased scrutiny for these medications. They want proof that not only is weight loss dramatic, but that safety is there. Phentermine and several other generic medications are approved for short-term use, but have not been approved for long-term use, and I'm afraid that proving that they're effective and safe for long-term use is going to be more and more difficult in today's environment. There are a number of medications that are used off-label, and again, these have to be used with caution. They cannot be marketed for that purpose. So bariatric surgery is probably widely considered the most effective treatment for obesity. And The quotes for weight loss have been in the range of 20 to 30%, so people can lose up to 100 pounds from bariatric surgery within a year or two. So pretty impressive results. The improvement in health is there. A number of studies have shown that you can reduce the risk for diabetes or even cure diabetes in 80% of people. Hypertension can go away, sleep apnea can go away. A number of comorbidities that are associated with obesity improve pretty well, pretty dramatically with these procedures. Unfortunately, these procedures have not been subjected to the same scrutiny as our medications. So there are randomized controlled trials of bariatric surgery, but only a few, only a handful, and none of them have the clinical outcomes like cardiovascular events that have been expected of our medications. So we're still waiting on those studies, and I think those are very important to see if we want to tout these procedures as safe and effective. They have shown a mortality benefit in non-randomized studies, but actually and surprisingly, that benefit is somewhat small, not as dramatic as one would think. So let's shift to diet, and I'm going to talk to you all about diet, not because I think this is a good business endeavor for you all. I know that's what you all are in Fuqua to learn about, but it happens to be what I know the most about. So I'm going to talk about diet a little bit. So I think probably the most important message I can give to you today about diet is that we do not know the most effective diet for obesity or even for health at this point. And let me say that a different way, is that we don't even know of a number of diets that have been used to treat obesity and health. We don't even know if any of those are not healthy or not effective. So I think that the important message that I would like everybody to come away with is we need to do a lot more research on diet and how it impacts obesity and health risk. And we should consider all of and any of a number of diets that are available. The one diet we know that does not work and is not healthy is the current American diet, which is high in fat and high in carbohydrates and high in calories. That one does not work. It has been pitted up against several other diets and not always been more dangerous. So I think that's important for people to realize. And I guess probably what we've learned from our research more than anything else is that the belief, or maybe the myth, that fat is bad for us is something we need to reconsider at this point. So I base that on a few things, but I'll get to that in just a second. The first thing I want to talk about is weight loss, because that's really, when we talk about diet, that's one of the key issues that we talk about, is how diet can impact weight loss. The other is how it affects our health risk. So from weight loss, we usually look at short-term randomized controlled trials to get our evidence. And there are a number of randomized trials that have shown that a number of diets can be very effective. A low-fat, low-calorie diet can be effective. A low-carbohydrate Atkins-type diet can be effective. An extremely low-fat diet like a Dean Ornish diet can be effective. And any of the diets that are in between there, Mediterranean diets, the zone diet, all of these can be effective for weight loss. The most difficult thing is maintaining the weight loss that results from these diets. And that is probably the holy grail at this point. Probably one thing that we need to work on more than anything is how can we behaviorally help people to maintain their diet changes and maintain their weight loss. Now, how do these diets affect health risk? Well, we base that mainly on research on what we call intermediate outcomes. So the ultimate outcomes would be whether or not people live or die, whether or not they have heart attacks or strokes, and whether they have cancer, these major health impacts. But intermediate outcomes are predictors of those outcomes. So a prime example would be the cholesterol level. And most of these diet studies look at cholesterol levels in patients following these diets. And we have learned a lot over the years about how different diets can impact your cholesterol. And what we found is that if you're losing weight, doesn't matter if you're doing it with a low-fat diet or a high-fat diet, if you're losing weight, typically your risk factors will improve. They might improve differently. Your cholesterol panels might improve differently depending on which diet you're on, but your risk probably improves simply by losing weight. So we need to measure these and keep these intermediate outcomes, blood pressure being another one, in mind while we're looking at these diets for weight loss, but recognize that just reducing our weight will be a major health improvement. What we know about our health risk also comes from our observational studies. So what I want to spend a little bit of time, I guess, debunking the belief that fat is bad for us from a couple of these observational studies that have been produced just recently. These are systematic reviews looking at all of the literature over the years and assembling these data together to try to figure out what diet factors impact our health. One study was done by a researcher named Minty as a systematic review who looked at the evidence and looked at the quality of the evidence and tried to determine how strong the causation was between a certain dietary factor and cardiovascular outcome or a stroke outcome, real clinical outcomes. And what these researchers found is that there's a strong relationship for improvement of health risk with vegetables and the Mediterranean diet and nuts. There is strong evidence that trans fatty acids, which we all know about as being bad actors, and high glycemic diets will increase your risk for health problems. And then there's moderate evidence to show that unsaturated fats can actually improve your health, reduce your risk for these types of diseases. What they found, which was interesting, is that there was very weak evidence to show that total fat or saturated fat intake was actually related to these diseases. So that is an assemblage of all of the data that's been done over the years, and it's pretty surprising, I think, that they came to that conclusion. Another meta-analysis that did a similar, looked at a similar question but focused on saturated fatty acids, also found that saturated fatty acids were not related to cardiovascular disease, and saturated fatty acid intake might actually improve your risk for strokes. So I think that the key message there is that we need to reconsider the evidence that we have to date, and we need to consider all different manners, all different types of diet approaches when we're trying to improve obesity and improve our health risk. So I'll stop there and let the next panelist go.
Great. Well, thanks, Will. So Don, I will pick on you next. So a couple of things from both Blue Cross Blue Shield is a large employer. You also represent large and small employers throughout the state. And you're dealing with obesity both as a prevention issue as well as the medical complications of obesity in terms of premiums. So what are you hearing about this, and what are your clients asking you to do about it?
So my approach to this is really pretty simple. I have 2 tenets and 3 questions. The first is, and really not to reiterate what's already been gone over, it is a problem. It's an epidemic. It is multifactorial. I bucket that generally in genetics, habits, and environment. And you can hang almost everything in those lines. The second piece that we recognize is that we as payers have a role and that we have a self-interest in trying to resolve the issue. The real issues are, though, what goals are we really aiming at? Can we realistically expect everyone to drop to a BMI of 25 or so? Not likely. Second is what works, because in general we would prefer to pay for things that work as opposed to those that don't. And really that gets to what are we going to pay for. So we actually use our own employee what we do know from a problem perspective is that obese members cost us 32% more on a per member per month basis. Overweight patients cost us 16% more, which actually means that your premiums are impacted by that amount. So it is a real issue, and that's direct medical expenses. The other thing that we've become increasingly aware of, although struggling to get a hold of, is that we believe that only a third of the total cost of obesity is really shown in direct medical expense. Probably 2/3 relates to presenteeism, absenteeism, functionality, workers' comp, so on and so forth. So the problem is probably larger than most of us recognize. We do use our population of about 4,000 employees as a group of guinea pigs to try to find what does work in trying to at least reduce the trend in weight gain. We do know a couple things. One is incentives work. And we've done that in a number of ways. We, for instance, base upwards of $750 of our company's contribution to health insurance premiums on our employees' willingness to do a health risk appraisal, to do some biometric screening, and then to partake in a quarterly company-sponsored health activity. We know when we take that out to our general book of business, small and large group employers, without incentives, we get about a 50%, less than 50% participation rate in these kinds of things. For our own employee population, it's 92%, and that's held steadily for the last 3 years. First identifying the issue in terms of payment, what do we pay for? We actually, despite how the industry gets painted, we actually have covered bariatric surgery for over 20 years. What I have gotten into, though, back in early 2000, was the issues with complications related to bariatric surgery, and really trying to make sure that it was safe and effective. We saw providers with readmission rates of upwards of 50%. That's not a problem with the surgery per se. Frankly, it's a learning curve, and does add a lot of costs. So making sure that those that are performing the surgery know what they're doing, using the right techniques, and thus we actually established one of the first centers of excellence programs in the country for bariatric surgery, and we keep, over the last 5 years, our complication rate related to bariatric surgery at well less than the non-centers of excellence programs. Childhood obesity. North Carolina has the 5th highest rate of childhood obesity. When I look at this from a strategic perspective, this is a disaster. Not only is it actually, as it turns out, from a short-term insurance perspective, obese kids cost us less than non-obese kids because they're inactive, and they don't go out and get hurt. If you look at the epidemiology of how kids generate medical expense, that's fine. But when we start seeing 11 and 12-year-olds with what used to be adult onset diabetes, type 2 diabetes, and know that in 20 years those kids will be getting their renal transplants, their retinal degeneration, so on and so forth, and cardiovascular disease, it is a major problem. So I guess to kind of stop and let us move the discussion forward, it is a problem. We actually do we provide nutrition visits, we cover office visits for the diagnosis of obesity, for evaluation and referral. We cover the one drug that's left, although we're not quite clear how we're going to really impact this, we are at least know that we need to make an effort and are doing that.
Well, Kelvin, as I said, is with Tenet Healthcare, a for-profit hospital system. And as you think about obesity, besides your employed population, because hospitals are big labor pools, you also have the physical aspects of obesity. How do you take care of a 400-pound patient? How do you move them around? How do you operate on them? This is a considerable challenge. And then you have the service lines. How is it impacting cardiovascular? How is it impacting orthopedics? How is it impacting complication rates of your procedures, especially in an era that we might be going to where you're going to have to eat the cost for complications if you're taking high-risk people. So how are you thinking about all that?
Yeah, as Kevin, as you mentioned, we are both a provider of care as well as being a large employer. And so we wrestle with a lot of these issues on many fronts. As an employer, we have about 57,000 employees across 11 states. We we do have workplace issues in terms of occupational risk. How do you manage patients who are obese and overweight? How do you staff appropriately? How do you institute lifts? How do you deal with some of the occupational and workplace injuries that result, backs, knees, other physical injuries? How do you make sure that you have the appropriate space and tables for these patients who are overweight? Vehicles for transport. So there are a lot of operational issues outside of just the delivery of care. It's also some of the processes and making sure you have the appropriate structure in place as well. We also deal with the issue that we have employees who are also overweight and who are struggling with some of these behavioral and physical issues as well. And so how do we help them to address that? We have programs that are in place to help them to understand the implications for leading less than a healthy life, and also things that are in place to support their leading healthier lives. We have a program that also is structured to give incentives. Don mentioned that, so that they are encouraged to do the right things for themselves. We think that that's important for them and their families and the community. Also because it sends a message and it models that behavior for the patients that they're providing care to as well. And so things are in place so that their insurance premiums are reduced if they're willing to undertake certain measures, increased exercise, changes in their diet, other changes in their overall lifestyle as well, to encourage them to modify those things. As a provider, and I like to say we're a provider and we're a partner. We really frame it in terms of inpatient, outpatient, and community. And so most people, when they think of us and other systems, they think about the inpatient activities. The fact is that for the most part, the incentives have been structured so that we've been rewarded for patients who come through the door who are sick and who we do our best to reassemble and then reintroduce into the community. We're moving, like many other organizations, beyond that. We're really talking about the health and wellness of our community. We're talking about integration, care across the continuum, how we help to better manage people who have these chronic diseases, and also how we begin to involve our patients in that partnership as well, so they're more informed, so that they're better engaged. If we kind of walk through a service line structure, one of the things that's been mentioned is diabetes. And so I can recall as a provider of care, my patients coming in and having some record that they had kept of their glucose readings and providing that to me, sometimes incomplete. We're working with some of our technology partners on multiple fronts. One is to work with our physicians so that they can have an electronic medical record in their offices. That record hopefully will make sure that information is accessible, but also more complete in the sense that we're working with not only the EMR vendors, but we're also working with mobile partners as well to explore the opportunity to have glucometers, which are already in existence, that have Bluetooth technology that will integrate with those electronic systems that will eventually feed into our electronic health records within our hospitals, so that we can clearly see when they are in or out of range in terms of their overall management, and to be able to respond to that prior to them presenting, and to re-educate them or make changes in their management prior to them presenting with these episodes of hyperglycemia or hypoglycemia as well. We are working with Joslin Diabetes Center, which is out of Boston. We have an exclusive arrangement with them to partner with us in some of our markets on the community aspect of things, so that we can better manage patients so they're not just coming into the inpatient setting and having these severe episodes. And so that's very helpful to everyone who's involved in their care. In terms of obesity, there are a lot of opportunities there. I mean, it's education of the patients. You've talked about diet, lifestyle, those things. We do perform bariatric surgery in our hospitals. I'd like to say that the procedure has advanced, that some of the things in terms of sleeve gastrectomies and some of the other procedures that are available today are less risk than they were previously. You have to make sure that you're selecting the right patient. We make sure that we have the appropriate clinical indications. I have received requests for people who want to do things that are outside of the clinical indications. I think that goes to Don's point as well. Since our focus is on making sure it's safe and high quality, we've had the appropriate conversation to inform them of what the evidence supports and continuing to encourage that. And so we're doing that. Also, our bariatric programs are centers of excellence. So we make sure we have the right surgeons involved, we have the right protocols, and that we've taken the right action prior to make sure that we've done everything before we take what may have a better associated outcome, but also is a surgical risk associated with that as well. Cardiovascular disease, you talk about cabbage. We're seeing, like most hospitals across the country, there's a decline in bypass procedures because there are medical procedures, there are less invasive procedures that are also available that have resulted in improvements in patients' life. But we're of course going to continue to perform that. We're making sure that those are appropriate, conducted in the right conditions. But we're doing stents, we're doing medical therapy, we're doing more intensive cardiac rehabilitation, which is a next step beyond just some of the basic, to make sure our facilities are appropriately situated and we have the processes and protocols to support that. Orthopedics, we are performing a lot of those outpatient now. Our outpatient presence is growing, and so there's the opportunity now to perform some of those things in same-day surgical procedures or short-term stays, and so we're making that transition as well. But you're seeing more and more people who are able and are good candidates to have that performed in different venues. I was talking earlier this morning about someone in the relationship between cardiovascular disease and cancer. And so there is an opportunity there too in terms of strengthening your service lines and product lines and oncologic care. Ultimately, we exist in a community because we're there to meet the community's need. We want to be the right partner with our patients, with our employers, and with all the other providers who are involved so that we can create healthier communities. I mean, that's ultimately our goal. And we want to partner with everyone on an ongoing basis to try to figure out how we create that structure and process so that can be achieved.
Don, as I'm listening to this, one of the kind of two themes, one is what's the patient's responsibility, the other way is how do we hold providers accountable for doing their piece. And obviously one of the things we've talked about with health reform is the role of payment and payment structures on, you're paying for gastric bypass, but you won't pay poor Will to go out and do diet counseling 3 times a week. How are you thinking about, how do you kind of think about both sides of those equation? Are we going to get to tiered, why am I paying for members in my pool being obese, and should they be risk adjusted? And on the flip side, are we thinking about reconceptualizing, will medical home take care of this? Will some of these other payment reforms give Kelvin more incentive to make sure he takes care of the people inside and outside, or gives Will more latitude to follow up his patients?
So I will avoid the obvious opening into the whole healthcare reform legislation, which did not address cost or quality in any substantial way. It was a health insurance bill, so I did get that in. I do see this as rather than a truth.
I'm glad you used past tense on the health reform bill.
It's not gone, and nor should it be. Rather than speaking politically in terms of truth or consequences, I would suggest that we need choice and consequences. So that one of the hallmarks of the American healthcare system is the insistence on choice. That needs to be tied with consequences or impact. And what you will see is a lot of our benefit designs, although this will be limited by the healthcare reform legislation, do look at trying to incent people to do the right things. We, for instance, for diabetics who enroll in our disease management programs, we waive the copays on testing and give them free glucometers, so on and so forth. So we believe that there need to be appropriate incentives built into both benefit plans and information that we can provide to folks to show what works and what doesn't. But there have to be consequences.
So, Will, one of the things we've heard is, how do we put the burden back on the patient? You're dealing with a lot of these people in clinic. You're dealing with a lot of people from different socioeconomic backgrounds. Are they in a position to accept this burden? Hank talked earlier today about making it easier for people. Is there anything in place that you see that's going to make it easier for people to manage this problem?
I think that putting the burden on them is not going to be effective. I mean, these people feel a burden already. So I think that the best way to make an impact, if you're not rearranging their stomach in some way that drives the way they eat, then is to support their behaviors and figure out how to support their behaviors long term, instead of just for a few months or 6 months, which we know that after that support is taken away, then they'll regain their weight and won't have had any impact. And the other is to change the environment and change policy that impacts these patients, that basically creates a different culture so that their choices can be healthier, and that their choices are driven by what's surrounding them as opposed to what their desires are or what they want at that moment. So I think that really it's a matter of, like you said, the talk earlier this morning, is to make it easier for patients to make the right choices.
Kelvin, as we've been talking about this, you are in this interesting situation where basically people come to you with their problems. You've talked about how you're trying as an organization to move outside, but at the end of the day, you're bound by your business model. This is going to be a challenge if you really have to. If you are going to be accountable for the population of people in the community compared to just the population of people who come to you as a patient, are provider organizations ready for that kind of responsibility? They're great examples we keep talking about of people that have done that, but they're also, I can count them on one hand.
So if you look at the present state, discoordinated, fragmented, voluntary, in terms of how we're structured, and most other hospital systems are as well, in terms of the fact that we have physicians who are part of our hospitals, but most of them are not employees. There is a challenge. So how do you begin to transform that? And we're doing some things right now, some of the things that I mentioned for which there is no reimbursement. We're doing it because it's the right thing to do for our community. We're also doing it in anticipation of the changes that are coming place. I mean, if you talk about accountable care, if you talk about bundling, and some of these other models that are on the table, for us to be able to succeed, we need to go ahead and put something in place. Are we ready for that today? No. Are we working aggressively to get there? Yes. Is it a significant challenge because it is a transformative model? Absolutely. But I think everybody who's involved in this, in some way, understands that. Now, how willing people are to commit to this, I think it depends on where you are. But we're pushing in that direction. One of the things is, how do you include the patient? And so the question that you asked is the thing that I've struggled with for quite some time, and it is the right responsibility, not the burden, but the right amount of responsibility to give to the patient, because in this new model, in this changing system, if the patient is not involved in an integral part of that as opposed to just being acted upon by a system, it will ultimately fail, because it will be wed to value and outcomes as opposed to just cost and cost efficiency.
Well, let me actually ask everyone to put their MD hats on, and like Barry, I'll warn you all that we'll open up to questions after this to the rest of you. But one of the things we talked about, and Hank, you missed this, but one of the problems is that there's actually no organized physicians group responsible for obesity. And so at some level, there's no way to advocate. I mean, it's interesting, you went to a public health meeting and heard the public health perspective, because there's almost no medical meetings you could go to and hear a medical perspective. How do we kind of move the public policy debate? How do we actually encourage and make the public aware that there's a huge need for research, because we have really crummy papers that come out every week, and why is it that research is inadequate and not the kind that you're talking about? But more broadly, how do we, it's hard, how do we organize to kind of really say, this is a group of people that's responsible for moving the ball forward? Because most organizations don't have one. You might have a chief quality officer, but you don't have a chief obesity officer. So So Will.
So I can speak to that from a couple of directions. I mean, first of all, I think that one of the struggles that we have right now are the current paradigms, and I think that so many people have entrenched beliefs about what causes obesity, that it's laziness or it's eating wrong, it's lack of self-control, it's a certain type of diet. That we need to just try to get rid of these certain current beliefs and just try to affect the problem and try to consider any possibility that might help reduce the problem of obesity. So I think that would be one major improvement is if we could at least push our biases to the side a little bit and just try to do some science. I think that you were right in that we need to try to have a more formalized society or specialty for obesity. And there is an organization called the American Society of Bariatric Physicians, which are non-surgeons who perform several different services for people who are trying to lose weight. But they're not widely recognized. It's not considered a subspecialty at this point. And there is a movement to try to develop a fellowship, although it's going to take a long time to develop such a fellowship so that we can have a subspecialty. But I think that would make major inroads.
Yeah, Don, and besides the medical specialty side, you're also dealing with the state a huge amount, and we don't have a chief obesity officer at the state either, other than the governor. So how do you see us professionally moving forward?
I think some of this is really understanding what the real impact of the issue is, and really, again, and from my perspective, understanding it's not just a direct medical expense issue, which is large enough in and of itself. If I look at, let's take the state, for instance, which is running a couple $100 million short on their budget as we speak, it's got to be translated to an economic issue, and really understanding that if we can deal with the issue, if we put the appropriate incentives in, it can help. And it really goes back to what Hank said, is you got to make a business case for what's going on. The real issue, and I think this is the challenge for device developers, pharmaceuticals, is what really works and what really provides value. And that's a tough issue. I do want to at least give a call out to the bariatric surgeons. There is an American Society of Metabolic and Bariatric Surgeons, which once you get to one end of the spectrum, which fortunately isn't the majority, but that group has been, in part because the coverage has been so spotty, they really have worked on improving the technique and the data around this. And I think as those kinds of studies and as professional organizations will take the bull by the horns and provide the information that's needed, that the policymakers can then move forward.
Yeah, Kelvin, I'm interested in your perspective. So Kelvin left Fuqua and went to get a public health degree on top of his MBA, so before he came back to return. So he should be able to address both sides of the issue with his training.
Without, and I'm reflecting on that because, you make that comment regarding you can go to a public health society, meaning you can have this kind of conversation. There is organization around it. And I do believe that in the absence of having that, then it's not going to be the coordinated effort that's necessary. I mean, I think that if you look at society this week, weeks before, there's a lot of information that's coming in the public domain regarding the projected increases in the percentage of our population that will be obese, some continued ruminations and hypotheses around what's causing it. I can't say that there's a concerted effort to address it. And I think without that, then we won't make as much progress, or at least we won't make as much progress as we could make as quickly, because we don't have a more comprehensive understanding and a targeted strategy to feed off of that. I'm also thinking about it in terms of from the provider side and some of the conversations that I have. I've had conversations with some of my colleagues of other systems and with some of the individuals from pharma. But outside of that, and those have been infrequent, it's been more around the fact that this is an issue and we should do something about it, as opposed to what exactly do we do. I mean, most of us understand our current delivery model or our current business model and what we can do to address the urgency, but in terms of stemming the epidemic, we haven't had those informed conversations that I do believe are necessary for us to be able to advance it. And we do need, I mean, obviously, this is a business. We need to make sure the models are in place to support it as well.
So just to kind of add to that, since we know what we've tried hasn't worked all that well, I do think it is going to mean trying to step outside of our current paradigms, whether it's a medical model or a public health model. The one book that I really have enjoyed is the Predictably Irrational, the whole field of behavioral economics, and trying to figure out why people don't act rationally, although they're predictably irrational in their behaviors. And again, we've just got to figure out where that really, what does impact behavior, because a good chunk of this is behavioral, as well as environmental. I will also note that screen time has gone up at about the same rate that obesity has. So,
Screen size, actually, screen portion.
Right.
All right, well, why don't we open this up for questions? The microphone's coming around.
Yes, hi. First of all, thank you very much. Very interesting opinions. Just finished my Duke MBA, and now I'm finishing my HSM degree. And my primary experience is actually in investment management, so nothing to do with this. But I am actually looking for an entrepreneurship idea because I think there's a lot of potential. So my question for you is the following. Besides research potential and probably a well-defined market and potentially, let's say, bringing all the efforts together, what do you think is the primary missing piece in this story? Because it seems like maybe there's no defined degree in obesity, or maybe we need more focus of resources. Maybe we need the government to intervene at a higher scale in this. But we need to bring all of you in an effort and in a structure, right? I mean, that's what it seems to me that is missing from the existing situation.
I'll take a shot at this one. I think it's really interesting. So prevention, if you think about prevention as a business model, there's two components to it. One is effectiveness and one is cost. And obviously, we've been talking about the limited data we have on effectiveness of these prevention efforts, but we've also not been talking about the cost. Will said, if you go see him in clinic, it's very effective, but it's also pretty expensive to do for 40% of the population. And so how do we think about canning whatever the effectiveness is and putting that in a box and selling that to people? So, I think there's a huge opportunity if we could find things that are effective to disseminate them and market them appropriately, as a way of rebalancing that equation. We could do prevention, but we have to do it at a different price point with better efficacy.
So the other point I would make is that, particularly as we deal with childhood obesity, is we need to go where the consumer is as opposed to trying to push our paradigm on it. I would suggest that social media is a real opportunity, and actually going to hear a little bit of that this afternoon. As an opportunity, physicians, by and large, are not well trained in nutrition. They're not terribly effective in dietary counseling. I would suggest that nutritionists are far better at that. So that, we really do need to get off of the physician-centric model for dealing with obesity. It's a social, kind of holistic view. The schools are another place that need to be dealt with here, and how can you market to schools and provide, again, cost-effective. Hank talked about the kind of what are the bottom lines for business, and it's people, profits, and planet. Maybe a little wellness in there. I would suggest from the healthcare side of this, it is quality access and value that we really need to go at. So if you want to talk about something I'm going to pay for, it needs to be quality, which means it produces some results. There's got to be accessibility to it, and it's got to be at a cost that the public is willing to pay.
There's another one back.
I have a question.
Go ahead.
Oh, me? I'm a bariatric surgeon, and I really believe that we cannot really tackle, the problem of morbid obesity with surgery in the large scale, because definitely there is no resources enough to tackle such a big problem. At the same time, I want to clarify that definitely when your BMI crosses 35, when you essentially go from class 1 to class 2, any diet, any medical treatment has been a failure. In fact, maybe your waiting, your waiting room is maybe different from mine, but when your weight is 400 pounds, really your only hope is really to have such drastic intervention. At the same time, really, because we don't have a very effective medical treatment, we don't have a very effective intervention for class 2 obesity. Surgery is effective, but also expensive and also difficult to implement in the larger scale. What about endoscopic implantation of device? Because that is a big opportunity to have a larger scale intervention and also maybe a lower cost. Until now, there's been a lot of work, but unfortunately not very successful. You have any opinion about this? Also, how the healthcare, really industry can really provide some good data about this endoscopic device? Because one of the problems is how we cover for it until we prove efficacy. And it's very hard really to develop a device, especially from a startup company that's very small, without too much money really to prove efficacy. In fact, most insurance, they don't cover this kind of device. Thank you.
Well, Kelvin, so I mean, from the provider side, how do you think about the technology? How do you make decisions about which technologies you adopt and when do you make them? And then maybe we could switch to Don and ask the coverage question.
And I thought you were going to go immediately to Don because that's whose direction I was looking in. So there are a lot of novel technologies at various stages that come across my desk. I look at it from really in two ways: is it effective, and then are we reimbursed for the use of that? And so it does come to that payer side because ultimately we have to be able to pay everyone who's involved in that process as well. So really a lot of it leans to, Don talked about the science and the evidence and how these societies are advancing it. That's at a different stage of the technology, but ultimately it is, are we going to be reimbursed for this if we include this as part of the service that we provide to our patients?
So this is actually, it becomes, we're kind of the bucket at the end of the spout because everybody wants to get paid. It is really an upstream issue in terms of policy of who's going to pay for the research side of this. So the healthcare reform bill did talk about comparative effectiveness. I would see that as the precise place that this ought to be funded very explicitly with good study design, good controls. When you look particularly at our small and individual markets, we sell our product on the basis of price. When you ask an individual customer, what are they willing to pay for? Are you willing to pay an extra $4 per member per month to cover the cost of research for health policy? No, they aren't. $4 per member per month makes a difference in whether someone will buy your product. So we view this as, we certainly have a role and we cover NIH types studies, but for life-threatening diseases in particular. But our customers are not looking to pay for the comparative effectiveness research, so it does leave a bind. But I would say this needs to be an explicit, federally funded, well-designed effort. And we won't pay for it until it's shown to be effective.
Is there another question?
Yeah, quick question for you. There's some analogy between the smoking problem and the obesity problem. And I'd be curious to your opinions about whether there are analogies there in attacking the obesity problem in the way that the smoking problem was attacked 20 to 30 years ago.
And so a partnership for obese-free kids.
Well, and in fact, we are engaged in that kind of activity right now. We've actually just given a $3 million grant to work on childhood obesity in kids. It's environmental. Can kids play? Again, kids in particular You're not trying to so much get them to lose weight as to maintain a healthy weight and to develop reasonable habits going forward. So again, if you break it into genetics, environment, and habits, I think we need to work on all three of those.
And I'll jump in. I think that we really made a major impact on cigarette smoking when we changed policies. And I think that trying to work on behaviors, we know that we can help people to quit smoking, maybe 10 to 20% of the time with behavioral approaches, but really impacting things is the change in policy. And those policies have been ongoing policies have been changing just in the last several years even though we've been attacking cigarettes for 20, 30 years now. So policy changes can make a big impact, and they can change people's behaviors, and ultimately that's what we want to try to do.
Right, and at all levels. So in our workplace, we have no sugar drinks in the vending machines. We have walking paths. I actually, when I do my one-on-one sessions with my direct reports, we do that walking a 1-mile gravel trail around things. We have health and fitness centers. Our cafeteria has healthy food options. I mean, it's not an easy problem. It's multifactorial, and it's going to take lots of little pieces at both federal, state, local, but also at the individual employer levels. Again, I would go to the school systems. Look at what our kids eat in the cafeterias at school, and look what's happened to physical activity. And again, not so much in trying to get them to lose weight, but to have them develop healthy habits for going forward.
I do think it's going to be more difficult, though. I just want to point out, there's not as much controversy about the health hazards of cigarettes as there are for certain types of foods. And then, there's not much argument that people who smoke would like to quit, and that people who are around people when they smoke don't like it when they're smoking. But these foods that we eat, people enjoy eating them, and they enjoy the social gatherings that occur around food. And so changing these paradigms and also changing policies with that in mind is going to be more difficult.
Maybe we should do something about the food at the state fair. So, Hank, I'll give you the last question. Move one over here, and then Hank.
Yeah, I just wanted to know what your opinion is on the role that payers have in reducing the obesity for a growing Medicaid population. For example, I work for a Medicaid payer in New York City, and I noticed that in certain low-income neighborhoods, the nearest farmer's market, for instance, would be miles away. And the cost per calorie for processed food has decreased in the last 20-some-odd years, but the cost for fresh fruit and vegetables has skyrocketed. So I want to know what your take is on giving this population the resources they need to better manage themselves.
So you're asking that question as a health insurance payer, as opposed to a governmental policymaker or environment? I mean, I don't know. First of all, our particular system, the Medicaid program is a state-run program, and so it does become a policy issue. The environment in which, not having availability of food is something that we as a payer work through our foundation in terms of trying to increase the availability of, the knowledge of how to eat a more healthy, varied diet. Let me just put it that way. But it really is, I see that as much as an environment and a policy issue. You're right, folks. I would suggest that not being able to have a safe place to play is equally impactful.
Last question.
Yeah, thank you. A couple of observations that I had just tying into our earlier discussion. First of all, Don just mentioned behavioral economics as being a key facet, and I have to agree with that, because if you really think about it, if you look at marketing terminology, we talk in terms of consumer. Well, when you look from the medical profession, the terminology is the patient. When you look at the insurer or the provider, it's customer or covered customer. But the reality is, I believe there is a huge opportunity to apply marketing strategy to this whole thing. In other words, treat the customer or the patient or those covered in the way a consumer package marketer might. And I think we could possibly deal with market segmentation models, things of that, and bring that to bear so that we can evolve certain types of solutions that are away from the one-size-fits-all, which I think we find ourselves into. And I do think behavioral economics is the umbrella, if you would, for dealing with this. So I think that's ripe, and I think part of certainly my initiative, and I just throw that out into others, that we ought to continue to push, because I think it's very ripe. Secondly, and I don't have an answer, it's more a question, I know the Institute of Medicine has like a food forum where they discuss these issues, and potentially is, let's say, a central reservoir for pulling together, because I like the idea of being able to have some representation in a centralized fashion coming from the medical community. So as I meet with them, I don't know what your feelings are, but it seems to me someone as esteemed as that body might perhaps make some sense. The third observation is someone just brought up the tobacco. Okay, thank you. All day Monday and yesterday, I heard multiple conversations about deploying tobacco industry tactics to the food crisis and obesity. And clearly, the Urban Institute issued a report about 1.5 years ago, which basically laid out the blueprint. All right, here's how we did it for tobacco. Now go and multiply and go take on the food industry and do the same thing. Here's all the tactics. So I think a certain group of, again, on the public policy side, are pursuing that avenue. And again, it potentially is effective. I mean, you're seeing with soda taxes, there's a lot of coalitions that are being derived with attorneys generals along with state legislators that I think perhaps could advance that a little bit. I think you know my opinion on it, but I would expect to see more and more of that. My only issue with it is you don't have, paraphrasing it, you don't have the smoking gun in the case of the food industry. So I'd personally hate to see that happen, but I would expect to see more of that. So again, it's just an observation.
Well, let me thank my panelists for joining us today. We're breaking now. Where's breaking for lunch, of course, in the middle of the obesity conference. Where are we having lunch? Back in the Winter Garden. All right.
We're going to have an announcement about the cake competition winners first.
Oh, okay.
But we can actually give a round of applause.
Produced by Duke University. Online at duke.edu.